Good morning, everybody. I'll be presenting on the recent advances in pediatric perfusion. While searching, I found a couple of review articles over the last 10 years. I'll be basing my talk on these 5 review articles, and common to all these 5 articles, these were the topics that these articles had covered, and these are the topics I'll be basing my lecture on. The first one was the target hemoglobin that was discussed the most. In fact, this is still something of a confusion in pediatric perfusion. Though the general trend in pediatric cardiac care is to accept lower hemoglobin, that trend comes from intensive care side. So, in fact, there's been a recent consensus statement released in 2019 where they've accepted hemoglobin of 7 in corrected patients and hemoglobin to the level of 9 in uncorrected patients. But this has not been the trend in pediatric perfusion per se. Pediatric perfusion, the hemoglobin is going higher, actually. And this is a very landmark article that has come in 2021. We had 20 hematocrit in 2004, 25 in 2008, and this is in 2021. Even though we've been following higher hematocrits in practice, the literature has come with a higher hematocrit in this paper. So this is a study between 2 centers in US where they studied 2 perfusion practices, one with lower hemoglobin and lower flows, the other center with higher hemoglobin and higher flows. And they found that the renal injury is much less with higher hemoglobin and higher flows. So sort of this states the minimum hematocrit on pump to be 32, and while coming off, the higher hemoglobin group has a hematocrit of 43, which more or less reflects the current practice that we follow. So even though the talk that transfusion induces multiple morbidities and mortality in perfusion and in pediatric care, this is one paper that has looked into it in more detail, and they've come out with a conclusion that when you add a unit of blood into the pump as a prophylactic so as to maintain a particular hemoglobin, it does not really add to the mortality. So the second way we tend to reduce our blood use is miniaturization. We have around 5 dedicated neonatal oxygenators now. So these are the current neonatal oxygenators, which first one was introduced in 2007. And now we have the really good ones with very low prime volumes. One of the problems with pediatric perfusion circuitry was the need for an arterial line filter, which almost took up 20% of the prime volume. Now they've come with newer oxygenators which integrates the arterial filter. Initially, there was a skepticism about whether the arterial filter will really filter the emboli, but now it's been found that it's probably better than the standalone units. So this is a graph that shows the trend in the prime volumes over the years. Most of them now have come below 50 ml prime volume. Even though the oxygenators have reached its limit, the majority of the prime volume, that's 3/4 of the prime volume, lies in the tubings. So the way is to reduce the length and reduce the diameter. To reduce the length, the common thing is mass mounting, so as to bring the pump head closer to the patient during the pump run. So this is a way of getting the pump closer to the patient. And about the other miniaturizations that we've done is reducing the arterial tubing size. From it was 316 on arterial. Now, for less than 2.5 kilos, they've gone to 1/8 arterial line. And vacuum-assisted venous drainage is being extensively used, so that and even for 2.5, they are using 316 venous lines with vacuum-assisted. So those are the volumes and the flow rates, accepted flow rates for these 1/8 tubings. And also with the hemoconcentrators, the common one that we use is the HPH 400. And now they've introduced a very small one, HPH Junior, which with very little prime volume and good filtration rate. It's expected that in future it may be incorporated just like the arterial line filter into the oxygenator. That's why it was published in '97, the idea, but then nothing has come into practice. This was an article in 2018. So people have gone to the extremes of miniaturization. And this is a table-mounted circuitry, which the console is away from the patient. And they have done, at the time of publication, they have done 3 neonates with such a setup. I think the holy grail they are tracing is an asanguinous prime in neonates. One of the articles talked a lot about the priming solutions. Just for mention, most of it is now plasmalite. Synthetic colloids like hydroxyethyl starch are equally good. There's no evidence against it that it's not as good as albumin. But nevertheless, albumin is what we use most commonly. Because of use of albumin, mannitol is decreasing in trend. The second thing that has been discussed is anticoagulation. Now, after this introduction of ACT in 1975, that's by Bull and co-workers. So after that, there's been no much real change in practice with regard to anticoagulation. But one of the primary things that was of an issue was the low levels of antithrombin 3 in neonates. So using this heparin, will it be useful in neonates was always a doubt. And I mean, always, is it optimal or not? So they found that the major issue is it takes almost 6 months for the antithrombin 3 level to come to normal adult levels. So because of this, that's why we need higher doses of heparin for neonates. And in spite of giving higher doses of heparin, there is a higher thrombin generation. And this leads to consumptive coagulopathy. Though bleeding in neonates is multifactorial, this is one of the factors that they tried to address. And in 2019, they published trial results comparing antithrombin 3 supplementation so as to make it to the normal level. But they did show significant benefits in terms of transfusions and decreased chest drainage in the ICU. But nevertheless, they didn't feel it's strong enough to incorporate it into clinical practice per se. So possibly they require a larger trial to look into adding this as a useful thing. And they've always tried to incorporate newer modes of thing with viscoelastic testing like thromboelastography and ROTEM. But the problem with these was that it takes a long time to get these results, and these machines are cumbersome to maintain. One of this paper from Boston where they analyzed 700 patients, and they used it during the rewarming phase so that you get the results early and you get it in time by the time you're off bypass. So they found, they just found that it can be used for individualizing platelet transfusion. But since TEG is much more difficult to maintain, the newer thing that has come and much more easier to maintain and gives much more elaborate picture of the coagulation pathway is ROTEM, is thromboelastometry. So this was analyzed in 44 neonates using ROTEM. This again during rewarming, not after bypass. And they found that it can be used to tailor the product transfusion in the postoperative period. But such ROTEM can be incorporated into clinical practice only after developing a proper protocol like this, where it's been developed and validated, and only then possibly it will come into a mainstream clinical practice. Till then, what we have is ACT. Coming to the other hot topic is myocardial protection. There's contention between different solutions. And as of now, we really don't know who makes the best cocktail. This was a recent study, RCT from Malaysia. They studied St. Thomas versus Del Nido. And they could find no difference in myocardial function, except that it's convenient to use Del Nido. This is a large study where they analyzed almost 500 adult and 500 pediatric patients. It's a meta-analysis. And they, again, the same thing, that they found no significant difference in myocardial outcomes, possibly a decreased rate of fibrillation in both adult and pediatric cardiac surgery. Cardioplegia is still a matter of personal choice. This is an article from 2013 showing the trend of the cardioplegia use in US, and the other showing cardioplegia use in UK. That's in 2019. So each has their own method of practicing. This is something of a last minute I got yesterday. So this is a paper from Marie Lenelon in Paris. So since it's such a large center, I just included it. There's a use of HTK. And they have somehow they've suggested that a single dose HTK may not be adequate for children undergoing ASO. So this is something of a, because almost 30% of centers in Europe use HTK. And since being from a large center, I couldn't discredit it. Rather than looking at solutions, they have gone on to additions on bypass, like adding nitric oxide. And they found that nitric oxide improves myocardial function and modulates the inflammatory pathway. So the cystic inflammation is less and you get a better myocardial protection. So this was one of the RCTs that came from Australia, showing nitric oxide at 20 ppm, where they studied 101 children. And they found that this nitric oxide reduced the low cardiac output in these children. A similar trial that studied very tight group, 40 neonates undergoing Norwood, 20 in the NO arm, 20 in the control arm. And they could not demonstrate a real clinical significance, but they could show that addition of nitric oxide decreased troponins. But they say possibly it's because of the small size, they could not show the clinical difference. And that's exactly why they're conducting a large nitric trial in Australia and New Zealand with almost 1,300 patients, where they are going to incorporate this nitric oxide and see the benefit. Possibly this will provide us more convincing answers. The other new thing that has come from the adult side to us is goal-directed perfusion. Now, this idea of goal-directed perfusion comes from goal-directed therapy that happened in the 70s and 80s when treating sepsis. So they said rather than trying to maintain parameters like pressure, urine output, think of trying to provide oxygen to all tissues. So think in terms of oxygenation and terms of cardiac output to the tissues. So that improved the sepsis outcomes. So from that, they studied, rather than trying to maintain flows based on BSA or weight and maintaining it on pressure and urine output, think of in terms of oxygen delivery, and so as to prevent anaerobic perfusion. Now this has been reasonably studied in, not too many studies, but then reasonably studied in adult. And they found on moderate hypothermia that anaerobic perfusion is prevented at 280 mils per meter square of oxygen delivery. And an adult trial also has been conducted which looked at the incidence of renal dysfunction. It's called the GIFT trial, goal-directed perfusion trial. Basically, that chart gives you an idea. So if you have a hemoglobin of 9 and if you have a patient perfusing a BSA of 1.5, if the hemoglobin is 9, flow of 3.3 is enough to give him good adequate flow. But if the hemoglobin drops to 7, you need to increase the flows. So based on the oxygen content of your perfusate, you need to change your flows. That's the basic idea of goal-directed perfusion. So there are systems like this now that comes from LivaNova that looks at real-time goal perfusion and gives you at the end of perfusion the quality of the perfusion that you maintain during the pump run. And of course, it has now come to adults. This is a paper from China where they have identified the minimum oxygen delivery that should be maintained on moderate hypothermia in pediatrics. So they found it's much higher than adult value as expected. So it's around 353. That's the value they found. And as soon as they published this, they've gone into a large trial to evaluate using goal-directed perfusion in pediatrics. Almost a similar result was obtained from France also. 340 ml is the oxygen delivery. Possibly this is a way to automation of pump, like self-driving cars possibly. This could lead to self-adjusting pumps. One of the common things that is perfusion pressure. Somehow it's a very common thing, but we really don't know what is the exact pressure we should be maintaining for children. So this is a study that came out 2 years ago that looked at, again, at renal injury. Renal injury has been taken as the surrogate of global perfusion in most of the studies, actually. So they found that maintaining perfusion pressure of 60%, above 60% of the age standardized mean is possibly an effective strategy in reducing renal dysfunction. Another way, the Boston group, I think, yes, from US, what they looked at is they looked at the rise in lactate that occurs with variation in pressures. They found this exclusively in neonates. They found that the mean arterial pressure is less than 25. This leads to a rise in, which is quite evident. But still, they don't know what exactly at where you should use. So possibly it's now 60% of age standardized mean. Another topic that has come is inflammation. The different studies of interleukins and cytokines. Possibly people are fed up of studying it the same way because it keeps producing the same results every now and then. But on the therapeutic side, what has come is a study of steroids in inflammation. A recent meta-analysis has been conducted wherein they've studied 555 patients. And as most of the studies were trending, there's no real big difference in inflammatory cascade stimulation. And what they have found is addition of corticosteroids definitely produce a major impact on postoperative fluid balance, but nothing in change regard to morbidity or mortality. In other morbidity or mortality. And this is a large trial, randomized trial comparing the use of steroids in pediatric perfusion. And there's another trial also being conducted. And these two trials will possibly provide us long-term answers. The other way we are following up inflammation rather than just looking at interleukins and cytokines, TNF, and all these things. Is a new direction this has taken is looking at the dysbiosis. That is, over the time they've noted that children with CHD tend to have pro-inflammatory bacteria in the gut, even before surgery. More of infectious organisms and organisms that are able to invade the mucosa at times of lower immunity. So this is a study, very small study. These are all very pioneering studies that they have done, where they have found that there is an increased incidence of pro-inflammatory gut bacteria in children, and these possibly contribute to the severe systemic inflammatory response syndrome that is noted in children. This is again a completely new form of looking at inflammatory pathways in pediatric perfusion. So this brings in, it's a bit of a new idea. So basically, if you look at plasma contains 11,000 proteins, out of which we know just 20 or 30. And we don't know what the others function, what they do, and all this. Now there are methods to analyze this whole plasma proteome, or whatever proteome, an organ proteome or plasma proteome as a whole, using several techniques that they have developed. So you can detect changes in this protein fractions at various disease levels, and to each disease, the plasma proteins change in different patterns. So using that, you can identify possibly proteins that are markers for a particular disease or particular situation, or those proteins that are causing a disease effect, and they can be used as therapy. So previously it was a genome and proteome studies that is going on. Now there's a whole series of things going on called the metabolome studies. So metabolome is the whole group of small molecules that are found in the plasma. Plasma, whatever organ, actually, it's for any organ. So they have studied metabolomic fingerprinting in children undergoing cardiopulmonary bypass, and they have found that aspartate, methylnicotinamide, these are small molecules that tend to spike in post-CPB, and when these tend to spike, these children have a sicker course. And we don't know what they are actually doing, but these are lead markers that have come. Possibly it can lead, search can lead to what exactly is causing these, and possibly we can target those situations. So that's just to explain what's proteomic study. They found that when you take Ross autographs and study, do a proteome study, from those that dilate and those that don't dilate, there's a gross protein expression difference in the pulmonary autograph. So these are the numerous ways these ohms, these are called the ohms of basic science, can be used to target practice in our. So this is just starting from 1989, every 5 to 6 years, they have conducted worldwide surveys of perfusion practices. And the last one was published in 2021, which was conducted in 2016. The 161 centers have responded. They have looked into basic things like, the number of perfusionists present and what is the practice of what are the components that are being used. It was surprising to see that 74% world over use vacuum-assisted venous drainage, something new. So this is by different regions, types of ultrafiltration. Even though we have a concept that MUF is going away, it's surprising to find that 70% of the surveyed centers still continue to use it. And this, like the use of alpha-stat and pH-stat in different. So the take-home message is that we are still fine-tuning the pediatric perfusion with more studies and RCTs coming along. So the general trend in neonatal and infant practice is to have higher flows, avoid low flows, and higher hemoglobin, miniaturize the circuit as much as possible, watch for newer anticoagulation studies like ROTEM, look for myocardial protection beyond just solutions, and watch for upcoming trials on steroids, nitric oxide, and goal-directed perfusion.